Hi, my name is Deborah Floyd, and I want to talk to you about my strategic plan for hospital readmission reductions. The agenda is stockholders, team members, project goals, screening tools, program initiatives, monitoring the initiatives, and of course, evaluation of the program. The stockholders includes patients and patients' families who can bear a financial burden with multiple readmissions, physicians who can bear a burden when their patients are readmitted multiple times, post-acute care providers, and also acute care facilities. The team members for our group include the head case manager, the care transition coordinator, the director of quality and risk, the critical care director, case managers for our ICU, our step-down unit, OB, joint camp, ER, and of course the CHF clinic. We have also included a respiratory therapist and a quality manager. Our project goals are to reduce unnecessary readmissions to 10% or less, and this is per the guidelines or requirements according to the Affordable Care Act. To prevent readmissions penalties for Medicare reimbursement, any facility that has a readmission rate of 10% or more, according to the Affordable Care Act guidelines, can be penalized 1 to 3% of their reimbursement rate according to diagnosis. This does not include all diagnoses. What it does include is acute myocardial infarction, chronic obstructive pulmonary disease, pneumonia, heart failure, coronary artery bypass graft, and elective knee and joint replacement surgeries. If a patient is admitted with these diagnoses and they are discharged and they come back within 30 days with any diagnosis, they could come back with pneumonia, they could come back with a urinary tract infection or a surgical site infection, that falls under these guidelines and you will be penalized for that readmission. The screening tools that we're going to use, we're going to assess each patient as they come into our facility. And one of the tools that we're going to use is going to look at length of stay, the acuity of the patient, the comorbidities, and the ER visits. We're going to look at the MIDAS readmission assessment. How much medication is this patient on? Of course, are there comorbidities? Do they have support systems? What is their likelihood that they are going to be readmitted because of other factors other than just this one diagnosis? And then we also have a quality readmission assessment as well that we do. The case manager is going to evaluate every patient to see what needs they have and to verify the diagnosis that they have. For example, if a patient has been diagnosed with congestive heart failure, have they had a heart echo? Do they have a cardiologist? Do they have lab to support this diagnosis? And if not, the case managers are going to reach out to the physician to ask for these diagnostic tools to verify that diagnosis, to make sure that this patient is being treated for this diagnosis as well as the diagnosis that they were admitted for. Just like every diagnosis is not excluded, we also have a out-of-scope group of individuals. These are going to include non-compliant patients, underinsured patients, chronic diseases, and also behavioral health patients. The program initiatives are going to include the LACE tool. This is the length of stay, acuity, comorbidities, and ER visits. Their scores are going to be looked at on a daily basis, and with the high score, we're going to be monitoring them when they are discharged to make sure they have the support that they need. We also are going to look at patient education to help these patients understand the importance of taking their medication as prescribed, going to their follow-up appointments, using the support systems available to them to help them manage their condition after they've been discharged without a readmission in 30 days. We'll also be having a daily case management huddle to look at the patient population to see what we have in-house and who needs support and what support we need to give them. Also, we will include the post-acute care provider meetings, getting together with the providers to see if we're meeting the needs of their patients. If they have patients who were readmitted or they feel like are high risk, have called into the office. We need to offer them something on an outpatient basis to keep them from being readmitted. We want to address those needs on an outpatient basis. Also, ER education. When people are discharged from the hospital and they come in for multiple ER visits, we want the case managers there to alert the head case manager so we can reach out to those individuals to see if we can address their needs to keep them from coming back and forth into the ER unnecessarily. Then we want to monitor our initiatives. We're going to track our daily LACE scores. We're going to track and monitor daily any readmissions. We're going to do our follow-up discharge calls to make sure that patients have the needs and support that they need. We're also going to track physician data. If we have particular physicians that are having a high rate of readmission, we want to reach out to that physician and see what the problem is. Is there something that they're not getting, their patients don't have access to, or maybe they're not aware of that we can offer to help them keep that readmission rate down. And we want to monitor the use of the support systems that we have in our hospital and in our community. That can be an uplift, a ride to your follow-up appointment. Do you have medication that you need? If your pharmacy is not able to get that to you, there are pharmacies that deliver. If you don't have someone to cook for you, we can get you meals. There's a lot of programs within our community that we can offer to patients to help them manage their care at home instead of having to be readmitted to the hospital. And then, of course, we want to evaluate our program. We're going to have monthly meetings with our risk manager and all the case managers and everybody involved to see, what's working, what's not. Is our screening process working? Are we missing some people? And if we are, why are we missing them? We need to change our screening program. Do we need to increase it to include more things to get our desired results? And at this point, we can look at our readmission rate. Is it going down? Are we getting the results that we want? And if not, we can adjust our program to meet the needs of the patients to keep their readmission rate down. Thank you.